I think we can possibly get started. I'm trying to think of who we might be missing.
Yes.
There's Regina,
Yes.
Barb, Jessica, Elle, Eileen. Well, you know what? It's like 104, so I'm going to kick off this agenda. And I haven't heard from, let me just check my texts from, oh, as I say that. Okay, Dr. Moss. So we'll go ahead and we'll get started. And Elle, I think this is going to be you. The first thing on our agenda is to go over the white paper and overview and then potential discussion about that. I am going to be listening. I have to take a call as if they actually call on time, and then I'll be right back on. It'll take me like 10 minutes, but I just wanted to throw that out there. And Elle, thank you so much, and it's all yours.
Thank you. I'm super excited to be here today. I'm also hopeful just to give everyone a heads up. Space is at a bit of a premium at Yale Law School. And so someone is in the space I booked, so I'm in someone else's space. And hopefully there'll be no knocks on the door. But my apologies if there's some sort of chaos here. We're going to cross fingers and toes that there won't be anything. Happy fall semester. I thought I would just give a very brief overview of the white paper that I wrote with Wendy, who is now off on new adventures. She's no longer with us at the Solomon Center, as well as Eugene, who is very much still with us. I think most of you know him. He's currently at another palliative care gathering. So he says a big hello. So I just was going to go over just high level what we wrote about in the white paper. Just kind of pull out some highlights. Also just talk briefly about why we decided to frame the white paper the way we did, and next steps, suggestions for next steps that we thought that came up during the drafting of this process. And I'm happy to take any questions. I just know we have a lot of stuff to cover today, so I don't want to take up too much time at the beginning, but I'm happy to chat about this for literally a week straight if necessary. This is really exciting stuff. I'm so glad to be a part of this project. And the work that we're all doing here. So without further ado, my colleagues, Wendy, Eugene, and I, with a lot of moral support from Abby Gluck and Jeremy Pilar, our new executive director here at the Solomon Center, put together this white paper that was meant to address just a foundational problem with pediatric palliative care, which is just access. So how do we make sure that as many children need palliative care actually can get it? So that was kind of the background question we had in mind. And from there, we were trying to think, what can both public, as in terms of the state of Connecticut, and private stakeholders do to address this problem? And what can they do right now versus what is going to need a little bit more time to build in terms of infrastructure or gathering funding or just getting things organized? From there, we ended up with identifying what we believe to be two major barriers to access in Connecticut today, and two suggestions for reforms that we think could be implemented. Nothing's easy, but more easily than some other potential options. So those barriers are, first, we think that insurance coverage is a major barrier. And the second one is a lack of training, particularly for frontline non-specialist clinicians. So I'll take both of those one at a time. So first, for insurance coverage, we decided to focus particularly on coverage through public programs, particularly Medicaid and Husky. We did this because for two reasons. One, we felt that since we're living in an unideal world and we can't really snap our fingers and just help everyone, that it may make sense to focus on those children who are doubly vulnerable. So those who are dealing with life-limiting conditions, but also are in otherwise economically or socially vulnerable positions. And those children are much more likely to be on Husky than children who have private insurance. Then rather have private insurance. So in the state of Connecticut, as near as we can tell, there are currently around 300,000 children who are on Husky. Of those, about 50,000 have special healthcare needs. So we thought that just as a first step, trying to align the population of children with special healthcare needs and the population of children who require pediatric palliative care services, we might want to, and probably will need to, do some more fine-grained analysis later, but just as a first pass, we thought we can see that those two groups might be more or less equivalent. And so we thought maybe we're dealing with a population of around 50,000 children who may be able to benefit from receiving palliative care at the start of their diagnosis. And these children, if they're already on Medicaid, then we might have an easier time making sure that they have coverage for palliative care, because Medicaid is not just Husky, but the federal government said that all state Medicaid programs must cover hospice care for children. So if a child is eligible for hospice, they get to receive all sorts of wonderful palliative care benefits. But if a child does not qualify for hospice, which I think preaching to the choir here on this call, we all know it's quite difficult for children to actually receive hospice services. There's a lack of resources, but also on the clinician side, the clinical side rather, it can just be difficult to determine when a child is actually approaching the end of their life. We found research, a number of research articles providing empirical data supporting, I think what's anecdotally known, that children might come on and off hospice, or, they may seem like they're approaching the end of their life and then they may rebound. And so for all of those reasons, tying palliative care to hospice doesn't really work for children. It doesn't work for adults either, but specifically doesn't work for children because of this definitional issue. And that's to say nothing about kind of the lack of knowledge among patients and their families. And so they also might feel that any discussion of hospice is akin to their clinical team giving up. And so I know we all are very familiar with these phenomena. So that's just a brief overview. All of those issues, we think that a good on the ground could be implemented today. Start would just be focusing on Medicaid, focusing on Husky, and trying to get children who are already enrolled in Medicaid palliative care. And we think there are two ways to do that. One would just be for children who are on Medicaid. The other one, which is the Massachusetts model, could be expanded to children who are on private insurance or have no insurance at all. So the first model, the first option within these, which is not the Massachusetts model, this is a model used by some other states, is to amend the benefits that just amend the state Medicaid benefits. And so saying that, okay, in the state, we know hospice is covered. Now we're going to say that all the services that are already covered under hospice, we're just going to get rid of that 6-month eligibility requirement. We're going to get rid of that hospice eligibility requirement. And we're just going to say that whatever services are already available to children who qualify for hospice are now available to all children who qualify as having special healthcare needs. And that's an area that needs to be teased out. But in other states, this was done through an expansion or just utilization of what's called the early and periodic screening, diagnostic and treatment benefit, or the EPSDT for short. And that's a special benefit for children. There is not an equivalent benefit for adults. And that says that if you're a state and you have a Medicaid program, you have to cover any necessary healthcare needs for a child. So, and that's kind of a flexible term, which can create some challenges, but in this space, it can be helpful because states can say, actually, we believe that palliative care is necessary for children with special healthcare needs. Therefore, we will cover palliative care for children with special healthcare needs. So, and that would be an amendment to the state plan, the state Medicaid plan. And so that would be permanent. We can also talk more later about, there's some things in the white paper about a permanent state plan amendment versus using a waiver. In the current political environment, I think that's another reason why we think trying to apply to the federal government for a waiver can be difficult. And because it's temporary, and we thought the cost benefit probably wouldn't work for Connecticut at this time, but we can talk more about that. That's why we thought state plan amendment. Other states have successfully gone down that path. And so we think Connecticut might benefit as well, benefit by expanding the benefits. And so the other option, which I think we might be talking more about later, is the Massachusetts model, which is a completely state-funded model. Medicaid is a joint federal and state program. So, but what Massachusetts has done is I think they get some federal money on the side, but for the most part, it's just coming out of the state budget. And Massachusetts said, we would like to have a program that's basically a payer of last resort. So if you do not have insurance, or you have insurance that does not cover palliative care, we will cover palliative care services. And Massachusetts has a big, long list. I think it's still a long list of services that are covered. I think we can all talk more. I think there might be other folks who are familiar with Massachusetts plan already to discuss what is and is not covered and how that program communicates and works with the Medicaid program and what this means for children who have private insurance. So that's kind of the overview of what we thought for insurance coverage. It can be a little bit technical, and I think there are definitely things that would need to be finessed and massaged. But my colleagues and I do believe that Connecticut could, well, the legislature, if the legislature gets moving, there aren't really big structural barriers in place that would prevent Connecticut today from deciding to expand coverage at minimum to children who are already on Medicaid. So very briefly, so the second barrier takes a little bit less time to explain. Is just the lack of training for frontline clinicians. So I think this parallels some discussions that this group has already been having. It's just how do we make sure that clinicians are, first of all, aware of palliative care and do not confuse palliative care with hospice care, that patients and their families are similarly aware of palliative care and do not confuse it with hospice care. And then also, thirdly, how do we make sure that frontline clinicians who are not specialists have the core competencies that they need to provide first-line primary care to the patients that they see, but also understand when referrals or to specialists are appropriate. So in the white paper, we go through, and this was my colleague Wendy really took charge in this section. She did, I think, a really wonderful job of laying out a menu of options for ways to help frontline clinicians develop those core competencies in communication with patients and their families, in identifying when a referral might be necessary, especially for clinicians who are seeing a broad variety of cases. So I think there's most of the research we were seeing was in pediatric palliative care in an oncology setting. But so for clinicians, maybe in an ER who might be seeing a bunch of different patients, some of whom might have chronic conditions, what does that look like? How do we make sure that referrals aren't getting lost? There are a couple of things that we can talk further about in this case. I think it's a little more self-explanatory, which is just working with, I think this would be less of a state-led endeavor. I think this would mostly be private stakeholders. So, people on the ground, clinicians, professional organizations, universities, to make sure that curricula are properly engaging with palliative care. And I know that this work has already been started and is really already well on its way. So my colleagues and I think the question here would likely be, what can the state of Connecticut do to make sure that these ongoing efforts are supported and to remove any barriers down the line that would get in the way of changing curricula, of any sort of practical issues, considering just the broad structural and systemic problems that are currently plaguing healthcare in terms of the lack of resources, burnout, whatever the heck's going on with the federal government. And so I think that would be kind of the, how can the state of Connecticut act as a bridge, act as a foundation for those efforts? And I think that stands in comparison to what would be happening with the insurance, which I think that would be more of a state-led initiative, because there would have to be some sort of direct communication with Medicaid at the federal level, or communications with various parts of the government deal with funding and just trying to get all that in order. So my colleagues and I think that both of these could be done right now. I mean, there's still would be work required to get both of them off the ground, but we think that these might be easier to attain now than, for example, trying to do a broad-based, improvement, like trying to get care quality up, but like in a very granular way. We think those are maybe secondary, not in that they're less important, but rather that they would kind of stand on the shoulders of expanding insurance access in expanding core competencies for frontline clinicians. So hopefully that made a little bit of sense. I'm happy to take questions, and thank you for listening. And it got a little bit rambly there, but my colleagues and I, we're very excited about this, and we're even more excited to just be of service to all of you. As we know, you all have amazing knowledge and wisdom and expertise, and we're all over here a little more in the jack of all trades side. So we're excited to just be able to facilitate your expertise and your wisdom, and do whatever you need to help keep this moving.
So thank you, Elle. That was, and I could listen to anybody ramble about that for like a long time, because I think it's so informative. And the best thing about it is you all have done so much research already that is helpful for us as we start making, decisions on how we move forward. I just have a couple of questions, and then if anybody else has questions too. One of my statements is, when I'm done with my questions, I want to hear from Jessica about some of the things that have been found in Connecticut, and then compare if that's what you were trying, if that's what you had to try and do where you are, how you compare that to where you're actually at. Because I just have a couple of comments, and I'm just throwing this out there. But when you were talking about the amendment, does that mean that what we would actually be trying to do is get rid of the criteria for hospice, the 6-month criteria? Is that the amendment, or can you just explain that one more time?
Yes, absolutely. Yeah, this is where it gets technical, and it's a little bit mushy, because there's no clear pathway for within Medicaid for attaching a true palliative care amendment. It has to go into one of a number of boxes where it doesn't quite fit. So we can't really Connecticut cannot just tell the federal government, hello, we would like to add a pediatric palliative care benefit. We're just going to add it right to our list, and we're all set to go. It has to go in a box that already exists. And so some of the big boxes, the 2 big boxes, are a state plan amendment, which is permanent. That means that the state plan is going to be changed forevermore until it's amended again. The other big box, which I mentioned briefly, those are our Medicaid waivers. And so those come in a couple of different flavors, but in Connecticut, I think the most popular one, or at least the most well-known, is the Katie Beckett waiver. And so that's a way for Connecticut to say, hi, federal government, we understand that, normally we have to do X, Y, and Z in our Medicaid program, but we would like to waive some of those requirements to make sure that we can serve other children. And so in return for waiving certain requirements, we're going to do some extra reporting. We're going to stick to some extra rules. And so in some cases, like the Katie Beckett waiver for helping, those children who wouldn't qualify financially, but need, long-term intensive care, and want to be at home rather than in an institution, the trade-off works. So we found that for palliative care, following the example of some other states, that there's a box within, the state plan amendment big box. There's a smaller box where there's this really neat benefit that already exists, and that's mandatory from the federal government, that says for all Medicaid programs, so including Connecticut's Husky, if you have to cover children, and for children, you have to cover medically necessary treatment. And the idea behind this is that, the powers that be thought, well, I think it would be a good idea to try to prevent illness in children because it lowers costs, it keeps children healthier. But instead of just saying preventative treatment, it's kind of this whole host holistic benefit. And because it's a holistic benefit, other states have found that they can kind of put palliative care in there. And so they can say, we believe that palliative care qualifies as necessary healthcare for children with special healthcare needs who have life-limiting conditions. So this would be an amendment to that benefit. It wouldn't really be touching the hospice benefit. The hospice benefit would stay where it is. It would just be an addition. But because, there are all these rules and it's highly technical, we have to get a little bit mushy with it. And we can't just say, okay, in addition to the hospice benefit, we're also going to have a standalone palliative care benefit. So it's just going to stick in the EPSDT benefit, and it will end up in that holistic space. And other states have had success with that. by kind of like reframing palliative care as actually a type of preventative care. But obviously there are costs and benefits doing this as well. And in the white paper, we go into a little bit more detail about some other options that states have used. I would just flag that other states who have not gone through the EPSDT benefit tend to not have fee-for-service care. Connecticut is one of the only states, I think it's Connecticut and Alaska, are the only states that don't use managed care organizations. And so for other states that have tried to expand their palliative care coverage through Medicaid, tend to have slightly other pathways because they're not using a fee-for-service model.
Al, can I just ask a clarifying question on that? Based on, you have I'd have A and B. A is the state plan amendment, the full out legal change.
Yes,
And then the other one is kind of the Medicaid waivers, and sounds like there's under the state plan amendment, there's adding that caveat or that clarification is defining palliative care as necessary, medically necessary. Do you have a strong feeling or a recommendation either way? What's either the easiest or the better route? And those could have two different answers, but do you have any thoughts on that?
So yes, I think my colleagues and I believe that there are a number of decent options. There's no, I think the fantastic option would be just being able to say, yes, we're done, snap our fingers, benefits there, and for all children. And I think that's a little bit what Massachusetts was trying to do. But just looking at Medicaid, looking at Husky, we think right now going down a Medicaid waiver route, it's probably going to be difficult. We, along with using the term colleague broadly, people we're not working with directly, but are working with other institutions, are trying to figure out what exactly is happening right now at HHS, what's happening at CMS, trying to figure out to what extent is the federal government going to continue to fund exploratory programs. So I think we've seen that some states that have existing big waivers, there's a type of waiver called an 1115 waiver or a demonstration waiver. And under that waiver, states can say, hi, federal government, usually there are rules about who qualifies for Medicaid financially. There are rules about who we can and can't help. There are rules about the benefit needs to be available to everyone in the state. We would like to vary those rules a little bit so we can expand care. But in exchange, we'll say, federal government, that the money that you give us is capped. So you're not going to be on the hook for this extra stuff. Is that okay? And the federal government said, yeah, sure. So that's already in place in Vermont. And so that's how Vermont got in their palliative care benefit, because they have this massive project where they're experimenting more holistic care. So they don't have as many structures and hard categories as the usual Medicaid program. But Connecticut does not have a big waiver like that. So we can't really fit in palliative care that way. So that's why we think waivers are probably a no-go right now. We do think that just based on some very weird technical details about the differences between the waiver application process and the state plan amendment process, we think it's probably more likely that the federal government would be okay with Connecticut adding this amendment. And we also feel more comfortable knowing that there are other states that have gone down this path, and it seems like it kind of works. This is also somewhat similar to what Hawaii has been doing. And so I'd also love to hear more from folks who are really in the weeds on this. I think we did work for this, and in my other work, I do handle Medicaid. I also see some clients through a medical legal partnership. So that's my understanding of Medicaid is I do have it, but it's kind of like it's from the very top and the very bottom. And I know a lot of people are in the middle where all the fun stuff happens. So I'm happy to discuss more and also talk more details. And also, please, anyone correct me if it's like, actually, like in that middle, that's not really what we're seeing. But regardless, is that, yeah, so we think it's state plan amendment, more of a chance that the federal government would approve it. The other option, which is almost entirely separate, would be that Massachusetts payer of last resort model, where you are not relying on federal funds. It's not going through Medicaid. It's just something that kind of sits underneath Medicaid. So for all children, they can access it if their private insurance is not covering something, or if they're on Medicaid and Medicaid's not covering it. So that would be, I think, if we had to rank it, we'd say kind of neck and neck would be the state plan amendment, and then the Massachusetts ESC model, and then waivers potentially, but kind of lower down the ranking now, considering our political climate.
Thank you.
Okay. And so, okay, that was one question. Then, my other question was, from my understanding, and this really could be to anyone, not just Elle, 'cause I'm not sure who might have the answer on this. But when we talk about doing palliative care, like let's say palliative care is the easier way to go right now with kids. I'm talking in the state of Connecticut, and you know, hospice is, we would transition on to hospice at some point. When we look at palliative care, is that really enough of what we want to support our kids with? And here's my question why. Number one, it doesn't really afford them a lot of visits, nursing visits. It doesn't really afford them. I'm not even sure that they don't get aides with that, but they may have aides, you know, anyway, or nursing anyway. So that could be all for naught. Who is covering all of their supplies and their DME at that point? And maybe that's all concurrent care, and Jessica's gonna set me straight when I'm done with this question. So is really the way we want to go more so getting them on palliative care, when really if we could change the hospice, not just the criteria, but getting more people to sign on for hospice when we explain it with concurrent care, like, are we really giving them the best we can by putting them on palliative care when they may be so chronically ill? And the other thing about palliative care that at least I hear from Dr. Moss is one of the biggest reasons for hospice is to be able to come out and pronounce upon death. And I don't believe we can do that with palliative care. So I don't know, Elle, if you have any remarks for that, or maybe Jessica, I'm not sure, but just some thoughts that came up in my head.
I can just, sorry, very briefly, and then I'll stop talking. Just to clarify in our white paper is that I think we use the term palliative care very broadly, and we'd also like to use it to encompass what is currently possible within hospice care.
Okay, got you. Okay.
Sorry.
Jessica?
No, I mean, I think that this is just so incredibly informative. And I just want to again speak to the legwork, Elle, that you and the team have done in doing your research and looking. I think the hardest thing about the Affordable Care Act, other than just in general, there being a lack of direction with how to implement a lot of the opportunities that are there, is that state-based programming, and really giving the states that control has led to inconsistency really across the board, and how it's interpreted and how it's used. I can certainly speak to my experiences both in more of a hospice-centric model of care through concurrent care, but also with my time in Florida with the Partners in Care Together for Kids program, which was a fee-for-service palliative-based model. And really, I think number one, the most important thing for us to recognize is next steps are being made. And as we are looking at different options for expanding the access, is being able to clearly define and identify where there are opportunities for concurrent care to really be utilized. I think because primarily hospices that have been servicing adults since their inception, they may be willing to bring on kids, but they still have their training, their regulation, their understanding of the hospice benefit as it applies to adults without access to concurrent care. Certainly, we have those opportunities where there might be an open access patient here or there, but it's not the typical function of the hospice team to have that expanded access to services. So I think it's more comfortable to accept that true end of life pediatric patient that may be out of treatment options, may be in a position that they are looking more at a hospice-centered comfort care model. However, because of the Affordable Care Act, because we have access to concurrent care, I think different states have certainly found their comfortability with eligibility. And I know you had spoken to that a little bit about that prognostic fine line that we walk because it's not nearly as clear with kids. But I think that also plays into our benefit with concurrent care, because with those concurrent interventions, prognostication becomes almost impossible. If a child is actively receiving chemo, well, we don't anticipate that they're going to die in 6 months because they're actively getting treatment, but concurrent care says that they still get hospice and chemo at the same time. So the approach that we've taken really across multiple organizations is really looking at how those treatments are impacting their longevity. If we were to remove those concurrent treatments, such as chemotherapy, a ventilator, if we were to remove any other interventions that are considered life-sustaining, that would not be, I guess, supported through the hospice philosophy, is there a chance that they would have some life-limiting event in the next 6 months? And I can say from experience that in more of an agreement with Medicaid and other payers, there's the understanding that that does qualify for that 6 months or less prognosis, while also still expanding the services for children so that they don't have to continue to choose between those two interventions. Now, all of that being said, that still only captures those families that are interested in proceeding with hospice and seeing the H word on their consents, which is hard, which is difficult. Also in partnership with providers and understanding and providing them the education of what hospice for children really looks like. And then also the very real possibility that as things are changing on the federal level, that there is always that chance that there can be a repeal of services offered through the concurrent care benefit. So I say all of that more to say that right now, I think we have a lot of opportunity for growth in how we can utilize hospice the way that it is. And we can expand a lot of the access to families that are already more than likely appropriate for hospice, but just haven't been captured. But I do think that we need to think longer term and in that bigger picture of offering something within an amendment or something that provides a little bit more stability to help capture those medically complex kids and give them an option for support, even if it is more intermediate and less, less comprehensive, I think is really kind of what you were speaking with to Tony Ann, is just the comprehensive nature of palliative care. It isn't nearly as much as hospice, but it is an option. It is a viable option to help protect them through that extra layer of support, so that if concurrent care were to be gone tomorrow, they would have a stepping stone to help get them into a hospice model of care when they need it at that point. My second thought, and I don't know if this came up in your research, Elle, with the Florida programming, and I can only speak to Florida because that's where I operated. I know that palliative care typically, at least in Florida, it's really we're operating in the blackish to red area here. So from a financial standpoint, it's not financially lucrative on either end for the hospice providing the services or to Medicaid, who is reimbursing the services. And so it really becomes that minimally necessary fee for service or reimbursement rate that is going to be able to provide the access, but is very, very much limiting the amount of care that can be provided. And so I think that that's really where a tremendous amount of the barriers come into play, is the willingness for a hospice to provide a service that, frankly, they're not financially going to be able to support in the long term, especially if there isn't that ability to convert over into hospice from the palliative care side of things. But that's really more of like a bigger picture, something that I have seen in that model. But again, knowing that palliative can encompass certainly hospice as well, I think it just speaks more to when that final layout comes as far as like reimbursement model and how that looks for visits and expectations. That was a lot of words.
No, I mean, and that makes a lot of sense. Melissa, you have a comment?
Yeah, this is just a little side comment. The concept of bringing hospice to the table. I think we have had this, I guess, informal vision of all practitioners being part of the full team. And whether or not hospice gets mentioned, they're there on the periphery or the background when the time comes. And I keep on going back down, Tony Ann, to the parent, I think it was Carolyn Torelli, who had said to you, if I knew you were there, I didn't know who you were when we needed you. And, I don't know if it's merely more of a passive concept, and I won't say passive's the wrong word, but peripheral concept that hospice and palliative care are there with the team, whether it's concurrent care or other. And I don't know, I'm not a practitioner. I just only know from the outside, hospice does not have the greatest awareness in the communities out there, and people have different perspectives and misperceptions about what hospice is and is not. So I think having hospice and palliative care bundled is a concept that helps promote the betterment and the care for the child. You can tell me if I'm wrong.
Yeah. I mean, and that's a good point. Does anybody else have a question for Elle or a comment for Elle or Jessica? Eileen.
I do, and I think Jessica's probably addressed it in part as well as Elle. Some of my recent interviews are with parents who have medically complex children. And in addition to what you were saying, Tony Ann, regarding lack of nursing visits or coverage, lack of DME, they asked about respite. And the respite care that we have for children in Connecticut do not include medically complex children. The staff is not willing to, or not knowledgeable to care for these kids. So there is no respite relief for the parents who are providing 24/7 care without a break. Another question was, in other states, there is a caregiver stipend, which can help offset. So several of the parents have given up their professional careers, their livelihood, to essentially be a nurse, a social worker, care coordinator, researcher looking for grant funding, paperwork, accountant. It goes on, and they don't get a caregiver stipend, in which some other states do offer for parents who are providing 24/7 care for their children with medical complexities. So I don't know, Jessica, have you had experience with that?
Yeah, I think several states do offer that stipend, or allow them to fulfill nursing hours that they may be eligible for through their Medicaid program. And I think what you're also speaking to further even reflects what Elle was mentioning about the sheer amount of people that are needing access to Husky or through Medicaid programming. And a lot of times that access becomes available to them because they have had to quit their job and they've gone down to a single income, which now puts them within the poverty level to have eligibility. And so I think that we already have the data to show that that's incredibly beneficial when a parent can be reimbursed in some way to help fulfill some of those nursing hours. And it also provides them, I mean, if we're just speaking from a psychosocial standpoint, it provides them with that empowerment of feeling that they're doing something and that they're participating actively in their child's care. I don't know where that stands in Connecticut, if that's a benefit they have. And then to the respite point, I know several states also have a respite benefit that's tied into nursing hours within the Medicaid program. So they may be eligible for 160 hours of private duty nursing, but they are also eligible for 40 hours of respite, and they can certainly cash in that time so that they can have a pediatric provider through concurrent care, so through their insurance, but they can have that pediatric provider providing the respite care in the home. But from a hospice standpoint, I think just going back to that second barrier, it's such a real barrier, which is really just expanding the education and comfortability of clinicians caring for children, and finding those individuals and partnering with them.
Thank you.
You know, and Eileen, you might want to do this call with me, actually. I'm part of the National Center for Pediatric Palliative Care. And it's run by a gentleman who I think started, I think his respite is called Ryan's House. Um, and I've been attending a lot of their meetings, and he recently asked, heard about the work group, and asked if he could, pick my brain a little bit. I have no, for me, being a hospice provider, you have to be on hospice for me to offer the respite benefit. It's not like we can just have people come for respite. So that's a question, I wonder how they're doing it. And I wonder, like, when you say that, when you said before about the family needing respite, are there any places in Connecticut that does offer respite or anything? I see already Jessica is like shaking her head no. So there is no place for it, and they would have to be on hospice. And I just keep going back to, and I don't know why I'm stuck on this, but even when you're trying to get a family to understand hospice, or you're trying to get a clinician to understand hospice, and we say, but they're giving their child chemotherapy, or they're giving their child whatever, they're on a ventilator, and because of the wonderful thing that we have, which is concurrent care, if and only if we took all of those things away, which is really how we try and set the criteria. If the disease ran its natural course, we're saying your child would have 6 months or less. It's not running its natural course because you're still doing curative interventions and things like that. Like, is that still a way to try and approach getting more people onto hospice? And I also have to say that I'm blown away. I forgot to mention this when Elle finished, by the number of kids in Connecticut who do have complex healthcare issues. I mean, that number is staggering. So I mean, trying to go these ways, which I agree with, and the amendments, and trying to bundle it all together, because I would love nothing more to be able to bundle them together, and really like a fee for service, depending on the amount of visits that certain child needs, to do it that way. But I just keep going back to, why can't we just get people to understand that we have concurrent care?
I think that is the question that has been plaguing everyone since its inception, truly. And there's been incredible work being done at the national level to help provide the education and provide the awareness of that benefit, but it primarily targets those that are already in hospice and palliative care, those that already have a fairly, at least an acceptable knowledge of what concurrent care could mean, whether they're able to actually provide that service or not. But what it hasn't really allowed us to do as of yet is really be able to infiltrate the ongoing other healthcare models that are existent outside of hospice and palliative care. Knowing that there's very complex relationships that are happening in the healthcare paradigm between provider and patient and family. Knowing that in oncology, there tends to be a very strong bond that happens between the oncologist and the patient, and the concern of that bond being broken, or the feeling that a provider may have at feeling like they are giving up. It's not just about the patient and family. And so I think a lot of that work really comes down to being able to provide the education outside of hospice and palliative care, and creating that awareness of how we can partner together in order to help serve that patient and family the best way, so that those, the 50,000 children in Husky can have at least the awareness that there is a support model available to them, even if they're not ready to sign on the dotted line. I think having a palliative care door to open that conversation would certainly help, because it's not the H word, and the H word is terrifying.
Right.
Which is why we typically use concurrent care when we're talking to families.
Right. And that makes a lot of sense. And like you said, and as we all know, palliative care is not sustainable. It's not a sustainable business model, because, the amount you're being paid for a visit and the amount of visits that you're allowed does not even pay near the salary of a provider that has to provide those visits. So like, how do you, so I guess the best way to go about it is to try some type of amendment where, this is kind of under the umbrella of palliative care. And I have to be honest, I'm going to really have to go back and listen to this again. I'm very visual. I need to, like, when we say under the umbrella of, I need to draw, like, on my whiteboard exactly what this would look like. I have taken pictures of it before because I've done it. And Melissa, I think you've seen it on my whiteboard, and I read it and I get it and I walk away, and next month I go, now wait, how is that going to work? But I think really that probably is the way I'm thinking that we may have to, move forward. And again, I might be asking a question that was already answered, but even when you're looking at this amendment, if it's some type of amendment that includes Medicaid, is this a federal ask or is this just a state ask?
Yeah, so this would be, if it's through Medicaid and a state plan amendment, it would be asking the federal government. And one of the issues also in this whole thing is you have to show cost neutrality to the federal government, which is something that we can discuss later. And I know that's a big issue when it comes in, especially in a fee-for-service model. If you're trying to decide, like just the idea of holistic treatment of total pain does not map on well to the fee-for-service model. So it's like, yes, that's an issue, but I also just want to flag, I think my colleagues and I are just beginning to really look into this, but we think this has also been an issue in Massachusetts. If anyone else knows more, please let us know, because they're running into the same issue of, where is the funding coming from? And then how do you really provide children, but also adults with wraparound services when then you have to go and break down the services into discrete chunks in a fee-for-service system, or even in managed care. I mean, at some point you got to just, who's paying what? So I think billing is a major bottleneck.
I will say, Elle, that I think there's a lot of success in the commercial insurance world, and what has been done with some of those bigger payer sources and how they have been able to open up access to care because they've had that documented research of under the preventative care guideline, right? Understanding that if we are meeting the holistic needs of a child, we know that they go to the hospital less. When they do go to the hospital, they tend to stay less. They have less intense needs, which means that there's less being spent on medication, potentially limiting DME, all of those things. But that's really how we open the door after concurrent care. After TRICARE was huge when TRICARE said, okay, we're going to have 26. But that's really what opened the door in the commercial world, was looking at that cost savings analysis and being able to provide very concrete evidence of how essentially we can save them money. And I think that that's probably a very similar, it sounds like, approach, even from like the Medicaid standpoint, and writing something in and presenting that to the federal government. Am I correct in saying that we're really looking at providing them the reassurance that this is a cost saving model and not something that's just being added on for no reason?
Yes, yes, it's looking, and it's from what we've seen, it's really based on, the idea that if you fund this, there'll be fewer acute care visits. People will be healthier, but if you're really just worried about the money, you're going to be saving money on the back end, and the whole system is going to be spending less overall, even if you're seeing an increased expenditure in these discrete moments for these discrete patients. Overall, there'll be less money spent.
Jessica and Elle, do you have specific state models that we could look at to show the cost build out on those things, just to give us a visual on how the numbers flow?
So I know the federal government does make the waiver and state plan amendment, some of that material public. And so it's a lot to sort through, but my team and I are happy to just point you in the right direction in these massive documents. But I did look through, and I think I've looked at those for Colorado, but I'm sure other states have that as well. And I don't know if there's any, I haven't seen Florida specifically, but I'm assuming it's out there somewhere.
Yeah, they definitely have released information as far as the PIC program is concerned. But again, it's not necessarily the most positive data. And most programs end up shutting down because it just frankly is in the red. But I also just want to, because I'm always an optimist, I also always feel it's important to provide the clarification that I think a lot of those programs, quote unquote, fail, for lack of a better word, because there isn't that ability to convert palliative kids into hospice kids. That they really are just finding themselves very comfortable in the palliative world with the intermittent visit, and sometimes even going into providing a level of care that is akin to hospice, but keeping them in palliative care and not making that conversion. Whereas I know in my program in Florida, we had 5 hospice patients, and financially that covered our entire PIC program of 30 kids. So we started making a model that said that every 5 kids, we can admit 30 palliative. And that's how we were able to stay in the black and even touch the green every once in a while. But I think that that's probably across the states what you would find is that it's not the most positive data, unfortunately.
Barb, you look like you want to say something.
I do, and I'm trying to put my hand up, but I'm working from my phone, Tony, and so thank you for reading my body language. And again, I'm not a money person. That is handled all at DSS, but I think what would be helpful for me is if we could see a crosswalk, and perhaps DSS can provide something that compares the Husky benefit for a pediatric patient who's receiving palliative care services versus a pediatric patient who's receiving hospice care, because I actually appreciate your comment, Tony Ann, about who's paying for DME, staffing, respite care, and I don't know what benefits that is covered under. So is there a DSS representative on this subcommittee who is a payment expert?
Oh, we have representatives. We're not payment experts. We're nurses too. Hi, Barbara.
Jasmine, I can't see anybody because I'm on my phone. So.
We're not experts, but I think this question kind of came up where we explored the Husky benefit last time, so I can send that out as well. But right now, there's really no difference kind of in palliative and hospice as far as benefit. So people who need palliative care would essentially build the services somewhat like hospice, but I would have to double check and send that out to the group.
I think that would help me, and it provides context for me as to if there's any disparate service delivery from palliative care to hospice. So I'd appreciate that, Jasmine, for my own learning.
No problem.
Yeah, no, I think that's a great point, Barb. And thank you, Jasmine, too.
And sorry, Jasmine, I didn't see you. I could only see myself.
It's
not
okay.
an expert on the phone.
I'm on my phone too. I was traveling from the office, so I understand.
I want to just throw in one thing. We had a baby on service, and Barb, you might remember this because I sent out like all alerts, and maybe Eileen, because we were looking for help with an APRN to be able to help us cover, because we only have one family APRN. But anyway, it was a baby that was born at New York Presbyterian that had trisomy 23 or trisomy 18. I can't remember. And they were trying to get the baby home. The family lives in Connecticut. They were trying to get the baby home on hospice, and we ultimately did. The problem was this whole fight, if you could believe, from the CAD pump company that was going to charge the parent. It was a whole big thing. The baby ended up staying in the hospital for 11 days before we could bring the baby home. And I'm talking extremely complex. We got the baby home. I think she lived for like another week. So we look at that week that baby was home compared to $205,000 a day in the upgraded NICU at New York Presbyterian. Like, those are the things that you look at. If we could get these kids home, look at the cost savings there. So I think it's definitely something we have to look at, is showing this as a cost savings, because sometimes, especially, I'm going to just say it, with the federal government especially, it's about the bottom line. So if we can show this cost savings, getting these babies home, getting these kids home, getting these young adults home, whatever, reducing the amount of readmissions, even reducing the cost of doing a pronouncement at home instead of calling an ambulance to bring them to the hospital to be pronounced. I mean, there's so many things, and I think that probably would also be a good element that we look at, is the cost savings. And it's like going back to my radiology days, 15 years ago when they came out with lung cancer screening. We used to do a CAT scan of the lungs and we could pick up little nodules that we would say, okay, in like 2 years, this is going to be a full-blown lung cancer, and the patient would have surgery. And the insurance companies and Medicare were refusing to pay for lung cancer screening. It costs about $150. Instead, they'd rather nobody have it. Then you're diagnosing the lung cancer. Then they're going through chemotherapy and radiation. Like there's no, you think about where we're at. And I think that would be a really good model to go after, is showing the cost savings.
I think it might also be beneficial in the interviews that are being done, if this is already a question that's there, but asking families, do you remember a time, or was there a time that you called or that you would have gone to the hospital if you would not have had support, or a time that you went to the hospital that you would not have gone if you had the support at home to stay home? Like if you would have had a hospice team that you could have called, and even just to triage what was going on. Because I think we find there's a lot of that savings as well when it comes to rehospitalizations, that sometimes the rehospitalization is rooted in anxiety on the family and just wanting to have an answer. And then because these are complex kids, they go to the ED and then they get admitted to the PICU. It's an automatic. There is no chance to just have a quick triage visit or have some quick IV fluids and do a tune-up and send them home. It becomes a much bigger deal. And they're always growing Pseudomonas, right? Like they're always growing Pseudomonas. And as soon as they do a trach culture, they're like, well, now you have to be admitted for 7 days. When in reality, their goals are to stay home. And they were just wanting to make sure that they didn't have like COVID, So
Right. So who can, I see Jasmine already sent something out there. Who can maybe we lean on to even try and find out what expenses there are in the hospital? Like what does it cost for a hospital stay per day? How do we go about finding that out? Does anybody have any ideas before we could throw it out to advisory next week too, but because people are very, funny about sharing their costs and stuff. Jasmine, were you going to say something?
I was thinking maybe OHS. I know they kind of, I believe they oversee like the payment system for hospitals.
Okay.
I can try to look internally, even though I know like the way that we pay is based on the DRG. I believe we sent that out before too, so it's based on the diagnosis, and they pretty much get like a rate,
right,
based on or like a bundle in a sense, based on whatever they're in the hospital for. So if it was pneumonia but I'm not sure about hospice. We can try to check internally and see.
That would be great. That would be great if you could do that. And one of the things on the agenda that I wanted to go over was, what data do we feel we need? I think the white paper has given us kind of numbers we need, how many kids in Connecticut, so on and so forth. But what other data do we think would be important? I think this price comparison would be great. I think that Eileen, you and I, if you want, can work offline. I know you've created the curriculum, I think already, that you were thinking about for a hospice internship.
I have some new ideas. So if you want to follow up, Tony, and that'd be great, regarding education. And there's a few of us who could brainstorm if we had grant funding.
Okay. And I see Peter with his hand up to probably say we are over time.
Yeah, sorry, there's another working group for waiting. I apologize.
Okay, so thank you all for this week. Another amazing talk. We'll have Melissa will put things all together here and send it out for us to review. And we'll look forward to Jasmine real quickly. If you could send out that DRG thing again, I think that would be great. And then maybe we'll just hand out some extra to-dos before we meet again. And Jessica, you'll be ready next week because you're gonna do your thing with the advisory group.
Absolutely.
Okay.